Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Michell Ruiz from Mexico. Dr. Ruiz was appointed as an attending physician at the National Institute of Rehabilitation in Mexico after finishing a sports medicine fellowship at the Plano Orthopedic and Sports Medicine Center in the United States. He's founding partner and attending physician at the Traumatologia Deportiva de Mexico, where he's also the co-director of the Sports Medicine and Shoulder and Elbow Fellowship. He serves as associate editor of the Acta Orthopedica Mexicana and is an editorial member and reviewer for several journals. He's been the past president of the Mexican Shoulder and Elbow Society. And if you've noticed, Dr. Michell has delivered several lectures on our channel. It's already reached a huge audience. And today it's my great honor to bring back Dr. Michell Ruiz for this wonderful eye program. Over to you, Michell.
Thank you. Thank you very much again for your kind invitation. It's such an honor to present here in your channel. So I was asked to talk about this topic that, as you are going to see, is a topic that fascinates me. And I would like to title like this: "The Forgotten Shoulder," because in many instances, we don't think that there may be chronic shoulder dislocations. So how do I manage these chronic anterior and posterior dislocations of the shoulder right now? So first, I would like to say that unfortunately, there is very little information on this topic in the scientific literature. It is not a topic that is very common to find in the scientific journals. So most of the information that I'm going to present in today comes from my own experience. And my experience comes like from many years ago. One of my first podium presentations at the American Academy of Orthopedic Surgeons was back in 2011. And back then, I presented the first part of my experience managing chronic shoulder dislocations. The title of that podium presentation was Results of the Surgical Treatment of Chronic Unreduced Shoulder Dislocations. And back then, many people were very interested in the topic, but also very concerned on how was it possible to have so many cases in one center. And for a first instance, I was working back then in Instituto Nacional de Rehabilitación, that was a national referral center. So many cases that presented all along the country were referred to us. So that is one of the reasons that we were able to gather many chronic shoulder dislocations. But unfortunately, that was only the first part of my experience, because in the years that came after, we had the chance, and still we have the chance of treating a lot of these cases still. So we know that approximately 95% of acute shoulder dislocations are anterior and 5% are posterior. And also we can see that, and reading in the scientific literature, that chronic dislocations are very frequent to find them in a posterior direction. And this is largely due to missed or delayed diagnosis. There is a very interesting review in the American journal, in the Journal of the American Academy of Orthopedic Surgeons, that was reported back in 2008, that they reported that in chronic dislocations, there was not such a high difference between anterior and posterior dislocations. They found 41% in the anterior, for the anterior dislocations, and 59% for the posterior. But as you are going to see, in my experience, incredibly enough, it is more frequent to find anterior chronic dislocations. Unfortunately, there is no population-based study that has defined the true prevalence of posterior shoulder dislocations, and there are many reasons for this, and we're going to dig in on why this is the case. Well, one of the first problems is that we there is a lack of consensus on when and how to define a chronic dislocation. There is no standardized definition of what chronic means. We can find in the scientific literature a lot of definitions, and some proposed definitions go from going 24 hours of dislocations, and some others propose 6 months after injury. So you can see that there is a wide range of periods to be considered chronic. But I think that starting from this review article dated in 2008, a chronic dislocation was defined as the one that was missed at initial evaluation, resulting in delayed treatment. And due to these characteristics, the close reduction in these chronic dislocations is generally ineffective. And I would say from my own experience that I will say that chronic dislocations are the ones that are going to need an open treatment, and in most cases, this is going to be after 3 weeks of the first episode. And the problem with chronic dislocations is that the late diagnosis is associated, as we know, that with many other pathologies, with suboptimal treatment outcomes. And due to these characteristics also, there are a lot of complication rates in these types of dislocations, and the complication rates are relatively high. Um, Unfortunately, and this is the case of Mexico, I cannot say that this happens in the rest of the countries all around the world, but once a patient with a chronic dislocation presents to a generalist, to an orthopedic generalist, that is the most common um, case scenario, uh, these generalists have the persistent misconception that these chronic shoulder dislocations result in minimal functional deficit and the pain is going to resolve spontaneously. Unfortunately, there is no supported clinical evidence for these assumptions. And the management for these chronic dislocations should be individualized based on chronicity, age, comorbidities, psychological status, and degree of disability. And you can start initially physical therapy in to improve some motion and pain control, but this may be the case in some anterior chronic dislocations. I have found, especially in patients that are very chronic, in patients that have more than 6 months of evolution, that they will try not to go for surgical treatment of, as their first option. And they will try to have some physical therapy sessions just to see if they have some improvement. And in many cases, they have some improvement, minimal, but some improvement in range of motion and also in pain control. But in most cases, this is not enough to prevent surgical treatment. But for the cases of posterior chronic dislocations, physical therapy has, at least in my experience, no benefit because almost all cases are going to be locked chronic dislocations, and they are not going to be able to recover any degree of range of motions. And referring to surgical options, they may range from open reduction with capsular labor repair to complex reconstructive procedures depending on humeral head vascularity, rotator cuff status, and associated lesions. And we're going to explore these options with a little bit more detail. So I can say, from what I have experienced in my reality, that true chronic prevalence likely is very much underestimated. And this is because these type of pathologies are very much present in low resource settings, um, also in places where they have very limited access to early reduction, And also because as I said before, there is a very heterogeneous registry definitions. But due to at least to the first two characteristics, they are not going to be reported in the literature because the facilities that receive this kind of patients are not going to be very active in the scientific literature. So first, what do we do when we have a chronic dislocation? Well, first we have to ask for any imaging study. And I will say that with conventional um, radiographic studies, you can have the diagnosis in at least 99% of the cases. In practically almost all my cases, I ask for an AP view or a true AP view, and this is particularly important in posterior dislocations. And an axillary view, that it is not going to be possible to have a very good axillary view, particularly in posterior chronic dislocations. So in most cases, we also need an orthogonal view to the AP or true AP. And I also ask for a Y view, scapular Y view, that is going to help us delineate which is going to be the direction of the dislocation. Um, I used to ask for just simple CT scans with 3D reconstructions. But as I'm going to tell you a little bit ahead, right now, when I am asking for a CT scan, I am asking for a CT angiogram because for me it is very important to know which is going to be the position and the localization of the axillary artery. And for me, it is important for a decision-making process to know if that particular patient is going to have a flow in the posterior circumflex artery, because that posterior circumflex artery flow is going to have a very, very, very large weight on my decision process analysis. Of course, it is also important to have an MRI, particularly in those patients that have more than 6 months of evolution, because an MRI is going to tell you how is going to be, which is going to be the rotator cuff status, but also it gives you a very good idea on which is going to be the vascular flow status of the humeral head. And that is also a very important fact to take into consideration in your decision in your decision process. Many years ago, like 15 years ago, I used to ask for a scintigraphy with rhenium. That back then, I thought it would help me to know if there was a vascular flow to the humeral head. Uh, Probably since 15 years ago, I have not asked for a scintigraphy in these particular cases. And I think having a good CT, preferably a CT angiogram and an MRI, is going to be more than enough to have all the information that you need for a decision making process. And first of all, I would like to tell you which was my experience with this podium presentation back in 2011. Because as you are going to see, the results were good, but not as good as I expected. And that made me shift all my decision-making process when I analyzed my findings with much more detail. So back then, I was able to gather 21 patients, 14 anterior dislocations and 7 posterior dislocations. As you can see, I was against all the scientific literature in the sense that my ratio was 2-to-1, finding much more frequent anterior dislocations to posterior dislocations. Now, my thought process is that still these patients were referred to me from the rest of the country, and still a lot of posterior dislocations are still unrecognized. So they were not referred to us. In this case, in this series, we had 12 females and 9 male patients with a mean age that, as you can see, that they were not, unfortunately, they were not that young. The average age of females was 66, almost 66 years, and in males, 45 years. The time from injury to surgery for the anterior dislocations was, in average, 9.5 months, and for posterior dislocations, 12 months, almost a year of evolution. The cause for anterior dislocations were post-traumatic in 14 cases, and for posterior dislocations, there were 5 post-traumatic and 2 post-seizure. For the anterior dislocations, because back then we thought that that if a dislocation had more than 6 months of evolution, the blood flow was going to be completely compromised, and there was no chance that we were going to be able to preserve the humeral head, the native humeral head. So we decided to do hemiarthroplasty in all these cases. And for the anterior dislocations, we did a deltopectoral approach. 13 cases were treated with open reduction and hemiarthroplasty. Only one patient back then was treated with open reduction and infraspinatus tenodesis to the heel sex lesion. As we know, this technique is known as a remplissage, using a metallic suture anchor. And this one patient made me change all my decision making process to the ongoing years. Back then, we did 5 hemiarthroplasties performed with a near monoblock prosthesis. We were talking that this was done almost 20 years ago, and 8 hemiarthroplasties were performed with a modular anatomic prosthesis. That it was a global advantage prosthesis back then. Many patients require some additional procedures. For these patients required a glenoid reconstruction with distal clavicle autograft that back then was a little bit unheard of. And right now, it is a procedure that is getting a lot of mentions in the scientific literature. Only one patient required a lateral jet procedure that, as I'm going to tell you, I'm not doing in any case right now a lateral jet procedure. And only one patient required back then a pectoralis major transfer due to subscapularis insufficiency. And this was because at the time of the MRI, we found that the subscapularis had a grade 3, 4 fat infiltration, and we decided to do a pectoralis major transfer at the time of surgery. For the posterior dislocations, all patients were also treated through a deltopectoral approach. And this is a very important fact that I teach all, well, back then when I had residents, I taught them, and right now I'm teaching my fellows that there is no need in most cases to do a posterior approach for posterior chronic dislocations. All can be treated through a anterior deltopectoral approach. 6 patients underwent a hemiarthroplasty combined with posterior capsular plication. As you can see in the image at the top, you can see the hemiarthroplasty, but also 2 metallic anchors. These 2 metallic anchors were placed in the posterior rim of the glenoid, and they were used to make a posterior capsulolabral repair to prevent a new episode, because after 1 year, these patients had a huge laxity of the posterior capsule. Only one patient required a glenoid augmentation with an autograft that you can see in the image at the bottom, that was fixed with 3 screws. And this is the reason that made me change my whole practice. Here you can see the comparison of the preoperative flexion, preoperative abduction, and preoperative external rotation in anterior dislocations. And as you can see, from a statistical point of view, there was a statistical difference. But to be honest, from a clinical point of view, there was not such a significant difference. So these results make me question myself if doing a hemiarthroplasty was the best that I could do for these patients. And for posterior dislocations, well, the results were not that different. As you can see, the comparing the preoperative flexion, preoperative abduction, and preoperative external rotation, although we found that there was statistical difference in these three planes of motion. Only clinically, I would say that the huge improvement was in external rotation for posterior dislocations. But to be honest, again, the improvement in flexion and abduction was not that significant from a clinical point of view. But I should say that these patients with anterior dislocation reported mild to moderate perceived disability, albeit they had not full recovery of range of motion. But most of them have moderate to severe pain. Postoperatively, almost all patients, whether it were anterior or chronic or posterior chronic dislocations, the pain was significantly reduced. And all patients except one in each group were very satisfied with the surgical outcome. And they were not satisfied completely because they did not achieve a functional range of motion according to NEAR criteria, despite being pain-free. So pain is a very important factor to be taken into consideration, but also range of motion. So due to these results, I began modifying my decision process analysis. So as I said before, right now, what I'm doing is not asking for a CT scan, plain CT scan for my patients. I'm asking for a CT angiogram to assess the patency of the posterior circumflex artery and see if, from my experience, I see if there is flow in this artery, then the possibility of preserving the native humeral head is extremely high. And I will go for trying to preserve the native anatomy of the patient. And also a CT angiogram gives me a much more precise visual feedback on where is going to be the location and the direction of my axillary artery. In most cases right now, I'm doing open reduction with open remplissage. I'm going to tell you a few tricks for this procedure. And as I'm going to show you, this remplissage is done placing the anchor through the anterior approach, and then I do the posterior suture retrieval for the knot tying. In no case, I'm going to do a lateralization of the subscapularis. I'm going to do a subscapularis tenotomy, and I'm going to repair it to its origin, to its native origin. I'm still doing very few, but still doing some pec major transfers in case of subscapularis insufficiency. I know that there is a big trend right now of doing latissimus dorsi transfer for subscapularis insufficiency. To be honest, I don't have any experience doing that for subscapularis insufficiency. But to be honest, I don't see the need in my personal experience, because with pectoralis major, although there is some rationale for thinking that it may not be the best option. In my experience, the pectoralis major is still a very good option for treating the subscapularis insufficiency. In case of huge glenoid bone defects, I'm doing adhesion procedures with iliac crest autografts. And as I told you before, in no case right now, I'm doing Latarjet in chronic dislocations. And I'm very emphatic with my fellows, telling them that in no case they should do a Latarjet in chronic dislocations, nor a coracoid osteotomy. I think the 100% of the particularly anterior chronic dislocations, you can do the reduction without doing a coracoid osteotomy. Doing a coracoid osteotomy for me, it is placing your patient in a much more risk of having a neurovascular injury during the surgery. Because if you preserve the coracoid and the conjoint tendon, you will always have that lighthouse that is going to tell you, please do not go medial past this point because everything is going to be in danger. And something that I am also very emphatic is never to use transarticular wires to fix the humerus to the glenoid. If you follow all the principles of a good release of all the fibrosis, of all the interarticular fibrosis, if you are able to have a glenoid dissection, if you're able to repair the subscapularis, if you are able to have a balanced shoulder, you will never have had the need of placing some transarticular wires. And to have a successful open reduction of anterior dislocation, you have to understand which are the hallmarks of this type of pathology. So first, and this is, I think, the most important thing to understand and to remember, is that in anterior dislocations, the posterior capsule is going to adhere to the glenoid surface. And that is going to prevent, first, the close reduction of this type of dislocations. In many cases, it is also very difficult because you're going to have an engagement of the heel sac lesion to the anterior border of the glenoid. But also, for me, this is the most important aspect of the chronic anterior dislocations: the fibrosis of the posterior capsule to the glenoid surface. You will also have, in many cases, particularly those that have more than 6 months of evolution and are not engaged, and they have some range of motion, even though they are dislocated, they're going to have anterior glenoid erosion. Many authors talk about the need of doing some capsular labor reconstruction. To be honest, I don't see any need for doing that. But you have to be very careful to not have any residual anterior instability. And you also have to be very aware that there are adhesions between the humerus and the neurovascular bundle, and you will have to be very careful during your dissection. And in some cases, you will have subscapularis insufficiency that is going to require some tendon transfer. And this is a axial view of a patient that I did surgery very few months ago. And this is what I want you to see. First, the head is in an anterior position with respect to the glenoid. And this is the fibrosis of the posterior capsule to the glenoid surface. And that is going to prevent you to do a close reduction. And this is what you have to release first to have a successful open reduction. Also, this is the axillary artery. So as you can see, it's very, very, very near to your humeral head. So if you're not going to do a coracoid osteotomy, what are you going to do? In most cases, even though you're going to have an engagement of the keel sac injury to the anterior border of the glenoid, doing a very careful and thoughtful subscapularis tenotomy is going to be able to free up this space is going to allow you to disengage the humerus from the glenoid. You're going to be able to do all the dissection from inside the joint, and in all through your case, the artery is going to be safe. In most cases, and now to be honest, in all my cases, I do a biceps tenotomy, and also that is going to give me some more space to free up this fibrosis from the articular space, and that is going to let me bring down the humeral head back to the glenoid surface. And in most of my cases that I'm doing open reduction, I'm also doing a remplissage. So how are you going to do a remplissage in these chronic anterior cases? In my experience, you can do this remplissage from anterior. Once you have done a subscapularis tenotomy, you're going to be able to fully externally rotate your humeral head, and you're going to have the presence of the Hill-Sachs injury to the front. And then you're going to be able to place from medial to lateral, from anterior to posterior, your metallic suture anchor just in the middle of the Hill-Sachs injury. And this is what I do in all my cases. I don't see the need to have more than one anchor. I think one anchor in these cases is going to be more than enough, but nothing if you're feeling a little bit more secure doing it with two anchors. I mean, that's also a very good option. And once you are able to place your suture anchor from the front, and you have free up that all that fibrosis from the glenoid, you are going to be able to internally rotate and reduce the joint. And then with conventional suture retrieval arthroscopic tools, you're going to be able to retrieve from posterior, that I will say that this is a conventional posterior portal. You're going to be able to retrieve the sutures from the front through the infraspinatus, and you're going to be able to tie at least your 4 or 6 suture limbs to do a conventional remplissage. And this is how it would look. Here you can see that we had some engagement of the Hill-Sachs injury to the anterior border of the glenoid. In this case, I did a subscapularis repair with one suture anchor and transosseous tunnels, and you can see the position of these metallic suture anchor just in the middle of the Hill-Sachs injury. In cases you have a significant bone erosion or loss of the anterior glenoid, I am doing Eden-Hibinet procedures with autografts from the iliac crest, and I'm going to fix it with 2 screws and washers, as I would fix a Latarjet. And as you can see, you can reconstruct huge bone defects of the anterior glenoid with autograft from the iliac crest. No need to do a coracoid osteotomy, no need to do a Latarjet. And in these cases, you can see that there is some inferior dislocation, subluxation, just after the surgery, and it is due to the extensive manipulation of the joint. But after a few weeks, this is completely recovered. You can see that there is a congruency of the joint here in all the radiographic views. Is there a place for doing a reverse arthroplasty in anterior dislocations? I would say yes. And this will be the case of anterior dislocations with humeral head defects that have a defect greater than 25%, or in those cases that maybe they do not have that significant defect, but they have very poor proximal humeral viability. And this is where the CT angiogram comes to play because if I see in the angiogram that there is no perfusion of the posterior circumflex artery, I will go directly for doing a a reverse arthroplasty. In very few cases, I'm doing right now an anatomic arthroplasty. And if I would do an anatomic arthroplasty, then I would think that it will be better to preserve the native anatomy of the patient. And I will also consider doing a reverse arthroplasty in the cases where the MRI or the CT scan will demonstrate a grade 4 rotator cuff fatty infiltration according to the Thomas characteristics, and this will be a typical case. As you can see in the CT angiogram, the proximity of the artery to the humeral head. In this case, we had a huge glenoid defect, but still we were able to fix it with bone grafting. And on the other hand, which are the hallmarks of the posterior dislocations? Well, first of all, you're going to have, in most cases, a McLaughlin injury. But also, I think most of the pain comes from axillary nerve compression at the quadrilateral space. Also, you are going to have a shortening due to this internal rotation of the shoulder, and particularly in chronic cases, you're going to have a shortening of the pectoralis major. In some cases, you're going to have a defect or fracture of the posterior glenoid rim. And in most cases, particularly if they have more than 6 months of evolution, you're going to have a residual posterior instability due to these patulous and lax posterior capsule. And in most cases, you have to do something with that capsule. And something very important is that I almost always perform a deltopexoral approach for these cases, and you can do the reduction without doing a subscapularis tenotomy or peel or lesser tuberosity osteotomy, because you can do the reduction through the rotator interval. And this will be the case, as you can see, and this is one of the huge problems of the underdiagnosis of the posterior chronic dislocations, is that they do not look to be grossly dislocated. But every time you see this light bulb sign, you have to think that there is a posterior dislocation. This is the same case. And as you can see, there is some engagement of the posterior glenoid rim to the McLaughlin injury, and there is no question in the CT scan that there is a posterior dislocation, a chronic posterior dislocation. And as I told you, this can be done through a anterior deltopectoral approach, but in some cases that I will add a a, a procedure to the capsule or to the labrum in the posterior part of the glenoid, then I will do it through a transdeltoid posterior approach. I always mark 7 centimeters distal to my acromion, and that way I will delineate where is my axillary nerve running, and that way I'm going to be able to do my mini open transdeltoid approach without placing my axillary nerve in risk of injury. I place my Fukuda retractor in the exact opposite way that I would place it in a Latarjet, because in this case, I'm going to place it in the anterior glenoid border. And then this gives me the chance of having a full view of the posterior glenoid rim. That is going to help me placing my suture anchors and doing a capsular labor repair for this type of patients. And as you can see, this will be a typical placement of the suture anchors in a patient that had some posterior chronic dislocation. And in many cases, I will also add a reverse remplissage to the McLaughlin injury, and I will place here, as you can see in the CT angiogram, I will place here suture anchor through the the tendon of the subscapularis, and then I will retrieve with conventional arthroscopic tools the suture limbs through the subscapularis, and then I will adhere that subscapularis to the McLaughlin injury, and that way I will have also a procedure that is going to prevent a new episode, particularly in those patients that even though I will do a posterior capsulolabral repair, they will have some degree of instability. I have gone away from some procedures. Many years ago, some authors said that disimpaction of the heel sacs injury and bone grafting it will be a very good idea. This is one of my cases that I did. They 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 all collapsed, so I'm not doing that anymore. Even though I had the chance of checking this patient 10 years after doing a disimpaction procedure. Um, the radiograph is not looking that good. The patient had a posterior dislocation. I did a disimpaction of the McLaughlin and then grafted. And to be honest, the radiograph does not look that good. But fortunately for her, uh, clinically she's very good. You can see that there is some difference in the external rotation comparing right and left side, but still she recovered a lot of external rotation. So if I'm going to graft these defects, I'm going to use a structural graft. I'm not going to disimpact from inside the head. So you can see that chronic dislocations remain a significant therapeutic challenge. Um, Unfortunately, they are more frequently encountered in developing countries. It is not a pathology that is going to be very common in developed economies. And our experience demonstrates that surgical treatment can be successful if it is offered despite prolonged duration of dislocation. And although prior reports describe discouraging outcomes, to be honest, our results have been more favorable. This is the table that was described in the article of 2008, and unfortunately, these case series have not expanded that much. So there are some basic principles in the evaluation of these patients. First, you have to assess the individual functional limitation, also the duration of the dislocation, the size of the humeral head bone defect, the presence of venous erosion, and also the status of the articular cartilage. And each type of dislocation, whether it is anterior or posterior, is going to present with distinct surgical challenges. And I see I hope that in the future, we're going to be able in countries like Mexico to be able to detect this much earlier in order to have timely treatment. And adjunct with the diagnostic tools, we are going to be able to optimize the preoperative planning, and hopefully we can improve the clinical results of these patients that are going in most of the cases through an ordeal. And right now, I'm trying to do more anatomy preserving surgical procedures, as you can see. So when chronic anterior dislocation is the most common presentation, at least from my experience, although posterior dislocations may remain underdiagnosed. And I think that is the case, at least in Mexico, that it is not that anterior dislocations, chronic dislocations are more common, but I think they are still, the posterior chronic dislocations are still very much underdiagnosed. The functional outcomes show a trend toward better results in posterior dislocations. The surgical treatment provides satisfactory results despite chronicity and associated lesions. And the definitive management must be individualized, anticipating common associated injuries and guided by the cost-benefit assessment. So right now, I am not performing hemiarthroplasties routinely, even in chronic, uh, say chronic, more than 6 months of evolution in anterior or posterior chronic dislocations. The only case that I will consider it will be a loss of more than 25% of the humeral head and or obvious signs of AVN. But as I told you before, I will consider first doing a reverse rather than a anatomic hemiarthroplasty. And the reverse arthroplasty only in anterior dislocations. I will not see the case of doing it in posterior dislocations, particularly in patients with glenoid defect and subscapularis insufficiency or signs of an AVN going on. So thank you very much, and thank you for giving me the space to share my experience, Hitesh.
Thank you, Michelle. Michelle, you can
I'm
stop sharing.
I'm
Yeah, you
going
can
to
stop
stop
sharing. Yeah.
sharing.
Thank you,
Thank you.
Michelle, for yet another wonderful presentation and great experience. I'm sure since 2011, you've done maybe, I think that kid series was around 25 patients, is it? 2011.
21 patients was back in 2011, and I
And
think
since
since
then,
then, probably 120 patients. Yes, a
okay,
lot of
that's
them.
going to be a great number.
Yeah.
You know what, Michelle, yeah. So let's take some questions. And one of the questions that have come up is, can you summarize the key principles if you're going for open reduction? Because there's a trend, right? There are some surgeons who have reported on lethargy, and for those where the humeral head is non-salvageable, you go for a reverse. And you have done on hemi before. So if we're going for an open reduction, you said no transarticular wires. So what are the other principles? Like a good capsulolabral reconstruction, a good release, and remplissage if there is a defect. What else?
I think the most important factor to take into consideration is the glenoid release. Just as you would do a shoulder arthroplasty, that you have a 360 release of the glenoid, you have to have that same release in this pathology, because otherwise you're not going to be able to recenter the humeral head in the glenoid. And that is only going to be possible if you take all the fibrosis. Um, for posterior chronic dislocations, I think you are going to need to do a capsulolabral repair, but not that necessary for the anterior dislocations. I think just doing a very, very thoughtful and meticulous subscapularis repair is going to be more than enough in anterior dislocations. But also, I did not mention, but I think it's also important. I will do a rotatory interval closure, both for posterior and anterior dislocations.
So good subscap repair and a rotator interval closure are the other key steps when you're going to do an open
Yes,
reduction, right?
yes, yes.
Thank you, Michelle. Michelle, we are also joined by Loiy. Loiy Al-Khatib is again practicing in this part of the world. He's in Dubai. Welcome, Loiy. Welcome to the show. Any questions to Michelle, please? Loiy, we can't hear
Hi.
you. Yeah.
Yeah, I'm muted. Sorry, guys. Thanks a lot, Mike, for this wonderful presentation. I think you covered
Thank you.
most of it. But the last thing I was about to add, this is the interval closure, rotator to interval closure, which is really important, especially in the posterior shoulder dislocation. I had a
Yeah.
case of a couple of weeks ago, completely missed diagnosis. Patient went to the emergency room. They did an X-ray. It was a posterior shoulder dislocation. You know, the bulb sign. Met from a junior colleague. They thought that it
Mm.
was a tendinitis, cuff pain. Okay, this is the
Mm.
take-home message here. You have a shoulder pain. You have a loss of external rotation. Pain. Patient can't move his shoulder. This is should be you should, and you have you can't the views, all the views cannot be done. I think it's worth it to think about posterior shoulder dislocation. Anyway, they did an MRI. MRI showed the posterior shoulder fracture dislocation. They
Mm.
managed to reduce it, and this followed by CT. I posted recently on orthobullets. That's just
Mm.
to throw a highlight on this important issues. Again, these are not common posterior shoulder dislocations, are not common, But once you see this is totally different animal. So my question
Yeah.
for you is, Michael, would you go for the modified McLaughlin and leave the posterior lateral for later on? What would be your strategy for these guys, and what would your expectations?
Uh, I've done some modified McLaughlin procedures. I've not that the results have not been that encouraging, at least in my hands, and that's why I'm still trying to do a posterior capsulolabral repair,
Mhm.
and I will do a reverse remplissage in most of my cases. Now, if the McLaughlin is more than 25% of the humeral head, then in that case, probably I will consider not doing a modified McLaughlin, but probably placing a structural graft. Um, Probably an iliac crest graft. There are some reports of using the talus dome, but in that case, I will consider doing that.
Awesome. So you're not a good believer in let's say in modified McLaughlin. What would you do if there's a LT fracture? Would you just repair it, or would just medialize it? Is there any strategy you follow with this if you have a fracture dislocation with that? Would you use that and the technique? What about the technique? So for that, would you still use the double row technique for it, or just go for the traditional one with the screws?
No, if I will have a fragmented lesser tuberosity, I think that's the perfect case of doing a double row repair, because that way I'm going to place my medial suture anchors in one of the borders of in the most medial border of the lesser tuberosity, and then I will grab the tendon along with the bone, just like a parachute, and hope for the best. Hope that fragmentation is going to heal as bone and to the lesser tuberosity footprint. But
Awesome.
in that case, I will not do a screw fixation.
You want to, yeah, sometimes some people they can add a buttress plate, so you can do the double row and just buttress plate to catch all these fragments. And
Mhm.
this is another way. I think that's my small comment for this session. Thanks a lot, Michael, and see you soon again.
Hope to see you soon again, Loiy.
Yeah, thank you, Michelle. I think that's all the questions that we have for this session. Thank you for yet another wonderful talk, and really look forward
Thank
for
you.
more in future.
Thank you again. Take care.
Bye.